Hi everyone, my name is Andrew. I'm a paralegal here at Lyles Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled OIG Work Plan 2019. Is your home health, hospice, or personal care agency in the government's crosshairs? I'm joined today by Megan McCormick. She's an associate at Lyles Parker and received her JD degree from University of Virginia Law School. She previously worked for a home health care agency before attending law school and has assisted with a number of home health audits and investigations. Megan has experience with auditing home health and hospice claims, identifying deficiencies, and assisting clients in improving their documentation. Megan has also extensive experience working on compliance plans and developing policies and procedures for home health and hospice agencies. I'm also joined by Mary Soul. She's an associate attorney here at Lyles Parker in the DC office. She focuses her practice on regulatory healthcare compliance matters, fraud and abuse, and reimbursement issues. Mary has represented a variety of healthcare providers, including home health agencies, psychiatrists, and dentists. She represents healthcare providers nationwide with an assortment of health law issues, including prepayment and post-payment audits, with Medicare, Medicaid, and private payers, and general compliance matters. She has also worked on a number of home health agency audits, providing feedback to the agencies in defending the claims to the auditing payers. And without further ado, I'd like to hand it over to them to start this webinar.
Hi everyone, so let's get started. To start with, just some background on OIG. OIG was established in 1976 to fight fraud, waste, and abuse, and it oversees more than 100 HHS programs, which includes Medicare and Medicaid. The OIG creates a work plan, which tells providers what OIG is most concerned about, and therefore should be audited. This doesn't mean that you won't be audited for any other things, but it does tell you what OIG is thinking about right now and most concerned with today. You should review the complete work plan to see what impacts your area. We will cover several areas during this presentation, but it's only a fraction of the total issues identified by OIG. Also, the work plan is updated on a monthly basis, and they also update which issues they believe have been resolved. So it's good to go through and see what they're currently concerned about and what they think has been fixed. So how does OIG pick what to include into the work plan? Well, there's a lot of different sources, and as you can see, like they can come from laws, regulations, directives. They could be concerns raised from Congress, HHS management, Office of Management and Budget. It's really just a lot of like far-reaching places that they can pull from. However, it's important to note that the work plan typically focuses on Medicare, Medicaid, and children's health insurance program issues because these three programs account for more than 80% of HHS's budget. So out of the 100 different programs that they oversee, 80% of their budget comes from these three programs. Therefore, it's easy to see why so much of the work plan does focus on them. So the OIG is alongside the fact that its general audit and investigative plan for the upcoming year is essentially broadcast to the healthcare industry. The publication serves to publicize law enforcement's program integrity concerns with respect to certain claims and services, types of providers, and improper conduct. These recommendations can be implemented immediately, or they might take some time to go into effect. However, it's important to note that most of the recommendations are implemented at some point. Sorry. The OIG also issues a listing of what's more commonly referred to as the compendium of unimplemented recommendations. And the 2018 edition has 25 of the unimplemented recommendations that they think are the most important. From these, they've told CMS or the other agencies that they've recommended that they do something, but nothing has been done on them yet.
And some of these recommendations have been outstanding for a number of years, which could lull you into a false sense that it may never be implemented. However, OIG does update this list, and like Megan mentioned, they list their top 25. So it is really important to be aware of at least those 25 because those could be on the market to actually being implemented by OIG.
And I would argue that this list is even more important than the work plan because it's been pointed out multiple times now as being an ongoing issue, and it's really lighting a fire under the agency that no, this is not only just an issue, but it's an issue that's been pointed out time and time again, and you have to fix it. I would recommend that you review the work plan and the compendium so then you know how to conduct a review of your practice so you can really understand what all the risk areas you specifically face. I wouldn't wait to be audited or wait to see for these changes to be implemented. Get ahead of them now and fix your problems.
Okay, so for a portion of our presentation, we're going to really just be picking and choosing some of the items listed in the work plan. Currently, OIG has about like 300 items listed, so obviously we're not going over all of them, but we have picked out a number that are either really important and applicable to TAC or just to kind of demonstrate the overall theme that OIG seems to be going for. So overall, HHS is responsible for resolving the federal audit report recommendations related to its activities. OIG issued 153 audit reports that contained 193 monetary recommendations totaling $648 million. So their concern here is that HHS has not regained the money that they have recommended be returned in their audits. And overall, OIG recognizes that CMS, has a problem with not returning not giving this money back. So just to kind of put it in perspective, CMS only has about 6,000 employees, but, just Medicare alone accounts for 44 million people. So how do they do all of this work? Well, CMS heavily relies upon contractors, which I'm sure you're aware of at this point. And OIG recognizes that there's a lot of issues with using these contractors, especially in regard to tracking to make sure that the contractors are doing what they're supposed to be doing and actually recovering the money that is claimed to be overpaid. So this item is important to note because HHS is working on this through increasing their audits, and it could be problematic for you because it could increase the urgency that CMS demands repayment. So you might be seeing the demand letters for any after any audit come with more frequency. For review of the statistical methods within the Medicare fee-for-service administrative appeal process. So the second bullet is really talking about when the contractors extrapolate on the claims. So after the contractor has determined based off the review of a sample of your documentation that, oh, this was overpaid, some contractors will actually extrapolate and say, well, if these 100, there was a 95% error rate, that must apply to all of the claims from this 2-year period. OIG has recognized that this use of statistics has not been consistent amongst the contractors, so they are concerned that this extrapolation process, is not consistent between all of the different regions. So it really would be beneficial if CMS took OIG's recommendation on this because that would help prevent extrapolations that are inaccurate. But at this time, since they have not necessarily, it's an ongoing process of trying to implement this item, one way that you can work on this as an individual is if you are audited and the contractor uses an extrapolation, you can hire an outside statistician to review the extrapolation used by your contractor to see if it is accurate. For most of the clients that we've had who've had extrapolated findings, when we've used an outside statistician, the majority of them are inaccurate in some degree and thus have been used as a basis for appeal. So this item is the concern about Medicaid sends out paper checks instead of using the electronic funds transfer for some of its providers. So this item is really, it is very specific to what CMS really needs to focus on, but you should be looking at this with an eye as to how this problem could potentially affect you. You know, just some very basic things. Having the electronic fund transfer set up would help to make sure that your check doesn't get lost in the mail, for example. But it really drives home the need for your business to have a real address that is registered with CMS and that is accurate. So if you move locations, for example, you really need to make sure that CMS is notified of that. Because if an investigator shows up to the address that's currently on your application and you're not there, well, that opens you up to an audit and to possible civil and criminal charges.
Well, they can also just shut you down for showing up and you not being there.
Yeah, so they can just, I mean, it sounds like such a small thing, but we've had clients where, you know, they only moved a month before, but they didn't make that a priority, and investigator showed up and, you know, was ready to revoke their number.
And once they put you on suspension for that, it can be 6 months to take you off, or never.
Yes.
So in this one, OIG is concerned with determining whether or not hospitals are being appropriately paid for the discharging of a patient. If a patient's discharged to another facility or home health, the hospital receives a lower DRG payment. And while this is limited, to hospitals, it kind of also goes back to making sure that the communication lines are open and that hospitals are aware that a patient has now been taken up into home health, so that way they can change or adjust their claims to make sure that they're appropriately paid. OIG is going to go through and verify that hospitals are being appropriately paid and that they're reporting or adjusting their claims whenever a patient is actually going to another facility or a home health care provider. And this one is related to kwashiorkor, which is a disease that's not generally found in the United States, but the OIG has seen a number of claims from hospitals for it. Kwashiorkor is a form of severe protein malnutrition that generally affects children living in tropical or subtropical parts of the world during periods of famine or insufficient food supply. So you can see why this is not a very common issue to arise in the United States. However, it has a very high reimbursement rate, and that's why it's likely showing up much more often in these cases. The OIG has determined that many of these payments are inappropriate, and therefore they want to go through a review if the diagnosis was actually supported by the medical documentation. It's also important as a home health care provider or a hospice that you're going through, and if one of your patients is there and their primary diagnosis is kwashiorkor, this would tell you that's something for you to look at. They do not think that these claims are typically legitimate when they come up in the United States. Therefore, if you receive a patient who has that listed as their diagnosis, maybe go back to the providers and see if they can, if there's something else going on, maybe a different diagnosis that you can base it on instead, because this is going to cause problems.
Or you may want to recommend that your patient go and see another doctor and get a second opinion, because as Megan mentioned, this is really not found commonly in the United States. I mean, I know it's hot in Texas, but there really isn't this, there's no famine or insufficient food supply that would cause such an outburst of this. So this item is, OIG is specifically talking about nursing homes and making sure that they have a registered nurse for at least 8 consecutive hours each day. But really what this work item is showing is that OIG is looking to see whether different providers are meeting their requirements for staffing. So not only making sure they have enough employees, but making sure they have enough of the right credentialed employees. So for example, for home health, you want to make sure that you have enough registered nurses to be able to conduct the OASIs. And you also want to make sure that your billing reflects the provider who did the service. So for example, we've had a client who had a number of claims denied because the contractor noticed that it was a physical therapy assistant who provided the service instead of a physical therapist, and this provider had billed for a physical therapist. So it's just small things like that that, you know, the contractors are noticing and OIG is really being made aware of.
With this particular one, you know, I have some issues with this in general because it's not clear to me that, you know, staffing levels are definitely related to strength of patient care. I mean, there would be times where, yes, of course, it's important that you're not overwhelmed, but it might be better to have the current staff than, say, hiring some staffing agencies, which might have bad employees. However, you have to comply with whatever laws are in place and make sure that, you know, you really are meeting those levels, because they'll go through and they'll check who you paid on your payroll, like who was there, were you meeting all of these requirements?
Yeah. Oh, also, you want to make sure that you check to see if there's any state law requirements. I know Texas has a couple of requirements for like what a home health aide needs to have in terms of skill levels and such. So you really want to make sure that you are up to date, not only with the federal, but with the state, especially if you're taking on Medicaid patients. So this is for hospice. OIG is noticing that there is duplicate drug claims for hospice beneficiaries. So they are noticing that some beneficiaries are going and using their Medicare Part D to fulfill some prescriptions that should be covered under Part A. I mean, this seems rather unfair, especially because if you have a patient who's, you know, who goes out and gets the Part D, I mean, how are you supposed to be able to control that? But one thing that you should take this item for is you should conduct an internal audit, you know, to look over your records to make sure that you're not accidentally billing Part D for medication that should be covered under the, you know, overall Part A Medicare.
With that as well, I think it's very important, since they're placing the burden on the hospice provider to ensure that patients are not going out behind your back to get medications, is that you are educating your patients, because you are going to be responsible if your patient is violating these rules. And like, I'm sure you guys are all aware, you know, you provide all the drugs that are related. Well, the patient has probably been told that, but it might need to be something that you reiterate more often, maybe get something more concrete in writing, just constantly remind them of this and check in, have, you know, when you're out at the home, have them say, like, are there any new medications? Speak to the patient and just see, because if you recognize that there's an issue, then you might be able to fix this before you get audited or have some type of long-term consequences from this.
Also make sure that your patients, anyone who's taking care of the patient, if they have, you know, what's the word? If they have someone who's in charge of their medical care, make sure that they also understand so that they don't use the beneficiary's Part D prescription, because, you know, you may have patients who aren't, you know, they're not able to leave, but their daughter or their son goes out and gets medication for them. Make sure that they really understand what can be used under Part D, but mostly make sure that they know what's included in their hospice care.
So in this one, OIG is concerned that some medical services should have been covered under the per diem payment made to hospice organizations. Medicare should not be paying for any other services related to the beneficiary's terminal illness and related conditions for which they're receiving hospice care. So this is very much building off of the previous example. But this is where beneficiaries, you know, are on hospice because they have terminal cancer, but then they also go down to MD Anderson and receive services. Well, it's obviously not okay. And they're holding, once again, the hospice agencies accountable for what patients are doing. So this also comes back to making sure your patients really understand what rights have they given up by electing to receive hospice, what are they receiving from you, and what can they receive from other providers. Like, for instance, we all know that if the patient fell and broke their arm, they'd still be able to go to a hospital and get treatment for their broken arm. They're not required to sit there and wait because they're receiving hospice. However, they cannot get any services related to what they are receiving hospice for. So that is what needs to make sure that the patient, their guardian, their children, whoever is involved in their care is well aware of what is going on and what they're allowed to do. I think that a lot of this comes down to maybe misunderstandings, but you are going to be responsible for what the patient does. So make sure that they are aware. Okay, so for home health, now these are ongoing issues of home health agencies. These have been brought up in previous work plans. They have been a long history of, which tells you that OIG takes them very seriously and does not consider this to be a resolved issue at all. OIG intends to have home health agencies audited to determine if patients are actually homebound and required skilled services. This is an ongoing area we see in audits we help work on, and it's just, you need to make sure that these are properly documented. And some of these, like homebound, I know is you're given the work or you're given the paperwork from doctors and you have to go with what they have, but you need to make sure that the homebound status of that patient is very apparent in the face-to-face documentation you receive or the other medical documentation related to the hospital care. Like, it has to be there because you will be responsible for a doctor's, lack of documentation.
Yes. For example, we currently have a client who's on their third stage of appeal because of a lack of face-to-face documentation. Now, for some instances, they believe that filling out the form that the home health agency had was sufficient. At this point, you should know, since 2015, you must actually have the actual encounter note. So if right now you realize you do not have some encounter notes, I would take this opportunity to go and see your providers. This particular client, they're having difficulties because these claims were from, 2 or 3 years ago, and some of the providers are no longer there, or the providers, aren't willing to give up the notes, which you can circumvent that. But it's just, obviously, it's a difficult thing, so you want to make sure you have those encounter notes and review the encounter notes contemporaneously. Make sure that when you get them, if you do not see, the primary diagnosis discussed in the encounter note, or if you don't see an instance of homeboundness, talk to the doctors, ask them why did they refer them to home health, maybe see if that patient can go and see the doctor again. It's very important that the encounter note demonstrates, that
need for skilled services,
need for skilled services, and that they're homebound. Because even if, obviously, if you were to look at the patient, they're homebound and they need skilled services, if it's not in that initial encounter note, it will poison the rest of the episodes.
Also, with that, make sure that if you're going back to get something now, you do not backdate anything. Everything needs to be properly documented for the date it's written, but you can have providers write an attestation to explain it. That way you can, justify what was done in dating it for the current date that they're signing it, but just adding to the record. Another thing to point out is that OIG is concerned by the consistently high error rate that they found from reviewing home health records. While the data shows that the error rate is actually going down, it is still considered very high and concerning at 42%. Now, I personally do not really trust this figure, as I've found that contractors deny all their claims when they're coming through for various reasons, sometimes often dealing with the fact that they don't understand their own rules. They'll apply the wrong rules. They'll apply, the current rules when these claims are from 4 years ago. Well, that's just not how it works. And so I've found that that error rate isn't accurate, but it doesn't really matter if it's accurate or not because it's what OIG believes. And OIG believes that the error rate is very, very high for home health agencies, and therefore that's why there's such a big target on these agencies. It's also important to keep in mind that cert audits are the only random audit you can actually receive. Lots of times people will say oh, these are random audits, but that's not true. Contractors have reasons for why they pull their audits. It's typically due to data mining or some type of report, an investigation, but there is a reason why you receive it. However, the cert audits are actually random in the sense that they are given out to look at what the MACs are doing. Now, the problem with that is they're determining whether or not the MACs are correctly denying services or paying for the correct services. But at the end of the day, it's the home health agency that's going to pay the price for these audits. So while they say they're looking at the MACs, this is all going to fall on you because you will be the one refunding for services that they determine MACs improperly paid.
Yeah, no, it's just an incredibly unfair standard that you're held to, because obviously, how are you supposed to respond? But the best defense And the best way that you can, defend yourself against these audits is to make sure that your documentation is following all of the requirements, and make sure that you get the face-to-face encounters from the providers prior to starting care.
And so OIG plans to look at the CERT audit results that they have to determine how to target home health agencies and determine who's a bad actor. And there are many different types of audits out there right now that are facing home health providers that you need to be aware of. And also you should be aware that just because you get one type of audit does not mean that you're in the clear. We have several clients that have multiple ongoing audits, and it just really reiterates the fact that this is a huge target that's being placed on home health care providers right now.
Okay. So this item, OIG is reviewing home health claims for services with 5 to 10 skilled visits. So, I mean, as you know, if a patient only requires 4 or less visits, it's considered a low utilization payment adjustment, or a LUPA. So OIG is looking at episodes that have 5 to 10 skilled visits to see whether home health agencies are trying to pad the episodes so that they can be paid for the whole 60 days instead of per visit. A way to make sure that you're not accidentally increasing the number of visits per episode is really, one, again, make sure your documentation demonstrates everything your nurses, your therapists, your home health aides do. I mean, everything that you can use to demonstrate that this patient has a skilled need, that can help go towards proving that the episode, that the patient really needed 5 or 6 or 10 visits. However, unfortunately, your practice isn't always going to have 60-day episodes for each patient. You will have a number of LUPAs, and if you don't, that is it's a trigger. It makes, CMS looks at your agency suspiciously, and it could cause you to be more susceptible to an audit if you have such a low number compared to the average.
That was what I was mentioning before about outliers being pulled from data mining. This would make you an outlier. If you have no LUPAs, that would be significant of the fact that you are not matching with what other providers in your area are doing, and therefore that would be a reason to pull you for an audit. So it is very important that you have a range. You should be providing exactly the visits that are necessary. If you have a very, very high number of patients where they're getting exactly 5 visits, that's going to be suspicious.
Yeah.
And that doesn't mean just make up a 6 or throw that in. I'm saying that you need to make sure that all the visits that you give are actually necessary, and that you bill for a LUPA when it really should be a LUPA.
Yes, and so it's important that you also inform your employees of this. It's important that you inform your outside agents, such as physical therapists or occupational therapists, because at the end of the day, you are responsible for the patient as a whole, so you want to make sure that they are receiving the skilled visits that they need and not what you need to make it not a LUPA. Okay, so this next slide discusses, really it's for DME providers, talking about the OIG has been looking at DME providers specifically for off-the-shelf back braces and for mobility device equipment. Really, this item demonstrates that non-physician providers are held accountable for physicians' incomplete documentation or for any mistakes that they make, or, unfortunately, if they're trying to be fraudulent, you'll be held liable. DME providers do not have the patient's medical necessity. I mean, DME providers are typically not medical at all. They're just, people selling equipment. But OIG doesn't care. CMS will audit them, And if they're not able to demonstrate the medical necessity for these devices, they, as the providers, the DME providers, will be held accountable.
And that's because, and I know this seems completely ridiculous and unfair, but they're the ones who are receiving the payment. Therefore, they can't, CMS takes the position that they can't audit the providers on this because providers aren't the ones receiving payment for the actual device. Therefore, they go after the DME providers. However, the DME providers are not in a position to determine medical necessity. It's completely ridiculous to think of the idea of a person without medical knowledge or background being the one determining whether or not a patient actually needs something, much less the idea of what doctor would then send them any patients if that provider was or the DME provider was constantly coming back to the doctor and saying, you know, I'm not really sure about this. I really think that we should take another look at this.
Yeah. Or actually, can you give me all your records? I want to just keep them all on hand. So, you know, on the off chance that I'm audited. Like, yes, it makes it so that really OIG is holding DME providers to an unreasonable standard. But at the end of the day, that is still how they're operating. So the best way that you can look at this and take this is, as we've been reiterating, make sure your face-to-face documentation encounter notes meet the requirements that CMS has.
And you're actually in a much better position because you have clinicians, you have people who have understanding of medical knowledge. You're in a much better position. However, I do know that it is similar in the fact that, like, it puts you in a terrible position to come back to, you know, this great referral source to be like, your documentation isn't great, and I really need you to put this instead. However, as awkward or awful as that sounds, it is what you have to do because audits are everywhere right now in home health. And if you haven't gotten one, just wait. It really seems to be everyone is going to get one, and you need to be covered in that case because these audits are extrapolated. They come back like you might have had $30,000, $40,000 in services denied, which is nothing, but then that's extrapolated to $1 million, and you are looking down foreclosure or other issues with your agency. And so these are huge issues, and it's not unusual to see $5 million audits coming back.
Yeah, I mean, as great a referral source as a provider may be, by checking their face-to-face documentation and counter notes with every patient, you might notice a pattern, and if you talk to the providers and they don't change anything, you really should consider not accepting referrals, because at the end of the day, it is your business that will be held accountable for providing home health care to those patients. And, you know, it isn't fair, but you really need to be able to protect yourself.
You are judged by the company you keep.
Mm-hmm.
So in this one, OIG is concerned that there's been instances of suspected child abuse or neglect of children that's not being reported. And they're pulling this from looking at different diagnoses or treatments that are provided, and then saying, like, these are suspected abuse, and nothing was reported on. And as many of you are aware, there are mandatory reporters for suspected child abuse in every state, and they're not being reported. It's basically what they're finding. Now, how this can relate to you is through elder abuse, which also has laws on, and Mary, I think you can expand on that.
Yeah, so Texas actually has a mandatory reporting law for elder abuse and neglect, and it applies to all medical professionals. If you're interested in the actual statute, it's available at the Texas Human Resource Code, section 48.051. But really, it just essentially says that if you are witness to, or you have any if you suspect that an elderly person is being abused or neglected or exploited, it's mandatory that you report that to the state or to the agency, depending on where you're seeing this patient being neglected. If they're in a home, then you would report it to the agency that's responsible for its home. And it's important that you report on any suspicion that you may have, because if it's a good faith report, you are immune from liability. So it's much better to be safe than sorry when it comes to reporting elderly abuse.
And also then helping your patients get into a much better situation. And so while right now OIG is only looking at children, they've put it on their radar that they're concerned with vulnerable populations. They put it on that they're concerned with abuse, and these can very easily then transfer to elder abuse. Also, the fact that we probably all would like to ensure that our elders are not being abused.
Yes.
And so make sure, though, your staff members are aware as well of their obligations. I know that can sometimes be a problem where the home health agency or the hospice is aware of reporting requirements, but not always staff. I know it's probably in your orientation packet, but how long has it been since, someone read all of that or went over it and they're given 50 pages on the first day? It's unlikely they're going to remember everything. And they should, healthcare providers should be aware anyway, but just in case, I would go over it at different times throughout the year.
Yeah, a best practice would be to make sure that you actually have a policy in place for how a nurse who's out in the home could report back if they notice
and they have
suspicion of abuse or neglect.
And having a manager who then maybe coordinates these reports, make sure to talk to them and informs the provider or the nurse, therapist, whoever is out in the home of what's being done about it.
Yeah.
So OIG is concerned that critical care by physicians is not being appropriately paid. These are time-based codes, and therefore only the time spent evaluating, providing care, or managing patient care should be reported. It goes back to just making sure that documentation, time, things like that are all being recorded in your notes as well. OIG is concerned about misreporting of time. The OIG is also concerned with outpatient physical therapy provided by independent physical therapists. They're concerned that care was not reasonable, not properly documented, or not medically necessary, as I'm sure that you all have, or at least the home health agencies have several therapists they work with. They should also be looking to ensure that all of their care is properly documented. There's many rules on what needs to be documented, ensuring that they are done by the right type of provider and every single thing is written down. Your notes are not cloned from visit to visit. This is a huge issue.
We've seen it in a number of audits where it is very clear that certain therapy assistants literally copy and paste down to saw patient sitting in chair, we got up and did the exercise, and
we had this conversation, and it's well, did you have the same conversation for, 60 days, every single week? I mean, and
it's particularly apparent when, there's multiple physical therapy assistants who've gone through, and it's the same person who they were there on a Tuesday, then they were there on a Wednesday, and then, 2 weeks later, and they have the exact same notes, the same numbers. It's very important that your documentation their documentation accurately reflects what happens. And if you start noticing a pattern where a patient doesn't seem like anything has changed, it's time to talk to that therapist.
And these patterns you can recognize by doing internal audits, which we highly recommend. Having someone in your office who goes through and makes sure that, one therapist or one nurse does not write the same things all the time, or very, very similar things. Because if you look at all of your notes put together and they all look the same, even though they might be completely legitimate, but if they all look the same, CMS takes the position that those are cloned, and cloned notes mean they didn't happen.
Yeah, and that's how contractors are looking at your notes. They aren't seeing an individual. They're not seeing the hard work that each nurse or each therapist has put in. What they're seeing is, repetition, repetition, repetition. I don't think any of this happened, or if it happened once, it didn't happen again. And as attorneys who have looked over notes and we are looking at them in a similar fashion to what the contractors will look at, we've also noticed, these are kind of looking the same, even though it's happening over the course of 3 weeks or 4 weeks or 6 weeks. So it's really important that you have a conversation with anyone who is taking notes about making sure that their notes are accurate, that they're not cloned from day to day, and that they include just really any kind of identifying factor that demonstrates that something new happened during this visit. So for non-invasive home ventilators, OIG is just concerned that, that these devices are being prescribed without being medically necessary. So really, if you have a patient that has a non-invasive home ventilator or respiratory assistance device, just make sure that it's documented, that it's medically necessary. It's pretty straightforward. So adult day healthcare services, OIG is concerned, as Megan mentioned earlier, OIG is really looking at vulnerable populations and adults with disabilities or the elder. I think adult daycare is pretty much just take care of those with disabilities. But, they really want to make sure that these facilities are following both federal and state requirements. So looking at this item is just really demonstrating that OIG is concerned about vulnerable populations and wants to make sure that agencies that are treating them are aware of all the law that goes into it and are applying it. So this can serve as a reminder to check into Texas law as well as federal law, because you might be following some of the federal things, but Texas does have some specific things, as mentioned earlier. There's requirements for home health aides. You really just want to make sure that you're following all that law, especially if you're taking on Medicaid patients, because that can be a source of an audit, is if you are not in compliance with all of that.
So OIG is also looking to see if IMRT, which is intensely modulated radiation therapy services, are billed correctly. I don't believe that this should be applicable to anyone who's listening to this, but it is something that they've made a point on of talking about. And then they're also looking to see about payments made to either provider-based or freestanding clinics. This is because provider-based facilities actually receive a higher reimbursement rate than freestanding clinics. And OIG is concerned about why or when those are being billed. I have some issues with them looking into this because provider-based facilities cost significantly more money to run, which would make sense then on why they're paid a higher amount. They have more expertise in the building. They have other benefits, and for a reason why you would want to be in that provider-based facility, especially for certain conditions. And so by looking at this, they're implying that maybe they should be reimbursed at the same rate, even though provider-based facilities cost more money and have other benefits towards them. So I think that it's also points out the fact that OIG is not necessarily concerned with ensuring that they're coming up with the best patient care. They're always concerned with making sure that the company or the programs are run in an efficient manner. So
efficient meaning that it's financially sound. This slide really demonstrates that OIG's concern is not necessarily with patient health and care, but their concern is the bottom line. They want to make sure that they are not spending money unnecessarily. And, some of these items, really, it is a fair look. OIG should be looking into it. But, when it comes to looking after provider-based clinics versus freestanding clinics and really being concerned that maybe they're paying too much, as Megan pointed out, they're obviously not looking at the reality of the situation and that it's more expensive to run a provider-based facility, so it should be more expensive, the reimbursement. And also, if you have patients that are in need of higher care, that they're not coming in with just like a cold or the flu, but they really need specialty attention, obviously you would refer them to a provider-based clinic so that they can receive that care from the specialist that would be available there.
And so with all that, just being understanding that OIG isn't necessarily going to be making the most sound decisions with these. However, you need to take into account what you're looking for and how to comply with those. Now with this one, we mentioned before, but CERT data was previously recommended to be used to determine who the bad actors are. And OIG is now going to go back and verify if CMS took action on their suggestions to use that CERT data to target the error-prone providers and reduce payment errors. So now they're going to go back through and make sure that CERT data is actually being used to, determine who to go after. So I think that we're going to see a significant number of increased audits based on CERT data, and that this is something that home care and hospices should be aware of.
So this slide is pointing out the items. OIG is concerned with CMS billing for patients that are, dead. Medicare Part C payments, so Medicare Managed Care, apparently OIG, after reviewing their records, have noticed an increase with improperly made payments to Medicare Advantage beneficiaries that had passed prior to the dates of service. And same with Medicare Part D, with people receiving prescriptions after they've passed. So really, the main thing is that you want to make sure that you are not billing for services for dead patients, except in the instances where, you know, the work has already been performed and you're billing because it's the end of the billing period or whatever. Just make sure that you are following the rules in accordance to how you're supposed to bill.
And from what we've seen from this, and we have seen several instances of billing for dead patients, 9 times out of 10, it's due to some type of mistake. You wrote the 12th down, but the patient died on the 11th. The services were actually rendered on the 11th, but you billed the date of service as the 12th. That's a problem. You have now billed for a dead patient. And they do go through, and you're wondering probably, like, how do they match this? Well, it does take a while to come back. But within about a year, they'll go through and match up with the Social Security Administration the dates of death and see when the patient died and what services were paid out after that. And then they'll come back to you. And like I said, it's almost always a mistake that has been written. So you need to be careful. I mean, you should always be careful that the dates of service are accurate and correct. However, especially when a patient has passed away, make sure that you are going back through and double checking that you didn't mix up. Maybe you wrote the day first and then the month. Well, like, just make sure you get all of these correct going through, because you will be revoked after you bill for the 3rd dead patient. So they do have a little bit of a leeway there. You
yeah, they recognize that there's some mistakes, that, you know, people are human and et cetera. But it goes back to documentation is very important. It's important to be accurate, and that includes checking to make sure what day it is. So if if you haven't already talked to your employees about this, make sure everyone who is going out to provide services, checks their calendar every day. Make sure they know what day it is, so that they are not accidentally billing for the day before or the day after, especially because, it could end up being that they're billing for a dead person.
And having someone internal who does audits and compliance checks on that would easily be able to recognize, like, this nurse wrote down that she did the service on the 12th. Well, definitely she was out there on the 11th, so let me double check with her. And then you can have her fix the note by, writing the correct date, signing the current date, and
acknowledging,
what occurred. So you can fix those then, and preferably before, those claims have been billed out.
Yeah. But as Megan mentioned, it is very important that you don't try to backdate and fix it. It is important to have that person sign their name and date their signature under the new date, because otherwise that is committing fraud. Okay, so we're coming back to that list we had mentioned earlier about the top 25 unimplemented recommendations. I'm going to point out a couple that are, obviously we haven't put all 25, but we can highlight a couple that are particularly applicable to home health agencies and hospice. So the second bullet, talking about how CMS should implement the statutory mandate requiring surety bonds for home health agencies. So there's already an existing regulation that the secretary was supposed to require that all home health agencies that enroll with Medicare obtain a surety bond of $50,000 or 15% of the annual amount that they're going to receive from Medicare, whichever is greater. That was written in like 1998, 1999. It still hasn't been implemented, hence why it's on this list of recommendations. But by it being on this list of recommendations, and it is the second one on the list, it is important to be aware that this change may be coming soon. And so it's just, it's important to know that at some point in the future, as part of your enrollment with Medicare as a home health agency, you may be required to obtain a surety bond. The fifth bullet, saying that CMS should take steps to tie payment for hospice care to the beneficiary care's needs and quality of care to ensure that the services are rendered accurately. So essentially, OIG is concerned that certain patients with particular diagnoses are being referred to hospice and kept in hospice because those diagnoses pay higher. So it's just one thing that you can look at as a hospice provider is to just kind of see overall what are the majority of your, what are the majority of the diagnoses for your patients, and to see if you may be an outlier if you are having too many of a high reimbursable patient.
Okay, CMS should require states to either enroll personal care service attendants as providers or require personal care service attendants to register with their state Medicaid agencies and assign each attendant a unique identifier. Well, this is really on states. However, something that you need to look out for, because there's a chance there's a good probability that this is going to come. PCS is subject to persistent fraud and beneficiary harm. They raised this as the reason for why that they need to be doing it. It's also important to note here, is like a lot of providers are not running their employees through an exclusion list, and so it could also be that your providers are excluded for something that you'd be scared of, something like a violent crime or theft of a patient, and these are issues that you should be aware of, but they might not necessarily show up on a background check. And even if you check your own state's exclusion list, it might not show up. People move. There's 40 different lists that you really should check to ensure.
And Texas requires that you are checking all of the exclusion lists, the federal and all of the states, to make sure, if you're a Medicaid, provider, that none of your employees are on that excluded list, and that none of the doctors from which you're receiving referrals are on the excluded list.
So going back, there's a lot of risk factors for that, and just be aware that this might be coming for you guys. CMS should require state Medicaid agencies to report all terminated providers. Again, this would just make sense that everything be reported, so that way you can actually search who's been terminated and why. But yeah, it would go back to then the importance of searching the exclusion list. The Office of National Coordinator for Health, IT, and CMS should strengthen their collaborative efforts to develop a comprehensive plan to address fraud vulnerabilities in EHRs. EHRs are both a terrible and wonderful thing. It's wonderful to be able to share records. It's wonderful to be updated. It's wonderful that you can look back at the previous records very easily and quickly. You don't have to carry the burdensome paper charts or worry about loss of them. However,
or worried about handwriting.
However, the problem with EHRs is that people are not properly securing them. They are not taking proper steps to ensure that they're being HIPAA compliant, and then that leads to cloning. It's very easy to clone. In the past, it would be harder to clone because you'd have to actually write it all down again. And instead of just writing what was currently going on, you're probably not going to just copy a previous note. Because in most of these instances of cloning records, it's not that the care wasn't actually provided, it's that the employee is so overworked, you're going to see so many patients, you're doing so many things, you don't want to waste the time to rewrite all this, and you can just copy and paste it really quickly.
Especially when it comes to, skilled nurses who are seeing a patient where really not much has changed between visits. Obviously, the patient still needs that skilled care, but I can very much see how a nurse would say, well, I'm doing the same thing as I did before. The patient's pretty stable. Here, I've changed a few numbers, but the narrative is the same. And that, it's an understandable reason why someone would want to bring the narrative that she originally wrote to the next day, but you just can't do that.
And you might think that, this employee of yours is the best. She's the best nurse you have, and that might be true for patient care, but at the end of the day, your documentation is just as important, if not more so, because it's what allows you to get paid, and no agency can exist without getting paid. So even if that clinician who's a terrible documenter is a great clinician, it doesn't matter. You need to make sure they're both. They need to be providing good care while also documenting. Okay, so with compliance, it's definitely essential. And so what can you do to avoid an audit? Well, on an ongoing basis, like we've talked about before, we recommend that you review the work plan and compendium of unimplemented recommendations. As I said before, the work plan's updated monthly, so you need to be checking this very, very frequently to be aware of what OIG is concerned with, and then how you can conduct your own internal audits, or you can contract with someone else to do an audit of your records to tell you how you're complying with these issues and where it's going to fall. If you take on some of these before you get audited, you can hopefully avoid these issues if there ever is an audit.
And I know I mentioned before that there's over 300 items currently listed on the work plan. We're not saying that you need to sit down and look through every 300 items. They actually have a search bar at the top, and quickly typing in hospice or home health or, related words that could be problematic, such as documentation, will help bring up the active items that are most likely applicable to yours.
And then you should have a compliance plan. If you take Medicare, you've already certified to the state that you do have one, therefore you absolutely need one, because when you signed up with Medicare, when you signed up with Medicaid in Texas, you agreed that you had a compliance plan, but everyone else should have a compliance plan too. Under the Affordable Care Act, they mandated that all participating providers have an effective compliance program. They didn't give a date for when that needed to be done. However, it can be clear from recent actions and enforcement cases that they're holding providers accountable for having one or not. And if you have a compliance plan that is implemented and is being used, you will get, they do look on that favorably. However, if you don't have a compliance plan, that can be used as another negative against you as a further reason for punishment.
So this is just a list of some of the issues that have been identified in administrative audits, such as billing for items or services not actually rendered, failure to fully document the medical necessity of services, billing for services rendered by a non-credentialed physician, or in this circumstances, if you're billing for services for someone who is not qualified to be providing those services, billing for services rendered to deceased beneficiaries. Really, the way that you can avoid almost all of these issues is through documentation. You want to make sure that your documentation is up to code. You want to, as we've been talking about, avoid clone language, describe in detail what happened. You want to make sure that you use the correct codes based on which provider was providing the services, such as if you have an occupational therapist versus an occupational therapist assistant, make sure you use the right codes to distinguish between the two, because CMS will be that petty and will look at that. Even if there's no price difference, they'll use that as a reason to deny the claim. So you really want to make sure you are meeting the requirements. Failure to provide adequate supervision over NPs and PAs, you really want to make sure that you have looked at the state requirements for that as well, if you are having anyone who qualifies for that employee status. So, as Megan had previously mentioned, the best way to review your documentation practices on an ongoing basis is if you can hire someone whose sole job would be to look at that. With home health agencies, I know that you're receiving, tons of notes every day per patient, and it's very difficult to sit down at some point and review all of them. So if you can afford one, hire a nurse who is well versed in this information. They will be best able to point out the discrepancies and talk with the nurses who are going out in the field, or talk to the therapist to make sure that what is actually happening with every visit is being accurately reported. This will best serve you and your business to make sure that you won't be susceptible to an audit later on when they're trying to look over your documentation. If you're unable to afford a full-time nurse, because I know that would be very costly, it's just important that semi-regularly you check your documentation. You grab a bunch of sample patients, especially patients that are particularly outliers for overall care, and review their documentation. It's much better if you can catch it before you're audited and before you billed, really, preferably. So as we also mentioned earlier, Texas requires that Medicaid providers have a compliance plan. You want to make sure that your compliance plan actually includes the requirements under federal law. So it's really important that you have a compliance plan that's that's constructed to reflect your practice, you as an individual entity, and not some general plan that you Googled compliance plan and have. It's also important to note that some Medicare Advantage require compliance plans as well, and some private payers are starting to require compliance plans. So at this time, you may want to take some time to review your contracts with your private payers, with any Medicare Advantage payer that you are enrolled in, and make sure that there aren't other requirements besides compliance plans, if there's other documentation requirements, if there's things that you're supposed to be sending, if there's, limitations. Now would be the time to review that, just to make sure that you are in compliance with, all of the requirements.
All right. So if anyone has any questions, you can put them in the chat now. Otherwise, you can contact us. Our information's on up on the slide, both our phone number, or the phone number for the firm, and our email addresses. And we'd be happy to talk to you about any issues that you have.
Yeah. So, thanks for listening.
Thank you.
But not any questions that are necessary.
Okay, so we have some questions here. We'll go through them as we see fit. So here's one right here. It states that Illinois requires nursing to be a core service with no contract staff.
I mean, you have to comply with whatever your statutory requirements are. So if you can't have contracted staff, then you don't have contracted staff, and you still have to comply with all. I'm assuming this was related to when we were giving staffing levels discussions. You still have to comply with that. So whatever it takes to do that, then would be what you were expected to do.
I see one here as well. What if the information pertaining to date of death that the auditing entity has is incorrect? We had to go as far as submitting a newspaper obituary.
Yeah, so we actually have had a similar case here where the date of death was incorrect. You do need to go through and then prove. You do not change what you build for the correct date of service, so you leave it as that, and then you go through and prove it by, showing them the obituary. It's very clear, their date of death was incorrect. Well, then once you prove that, then it won't be considered billing for dead person, but you do have to bill for the correct date of service no matter what.
And what about the reviews of improper denials by Medicare Advantage plans? This might have been.
I mean, if the question's asking about the appeal process, if you've had claims by Medicare Advantage plan that have then since been denied, every Medicare Advantage plan has a different appeal process. It is very frustrating, but since it is a Medicare managed plan, you do have a right to appeal. However, you will have to get on the phone and try to get in contact with someone who can show you how you can appeal. Sometimes the appeal process is located on the website. I know for United Healthcare it is, but if you can talk to someone, that is typically the best route.
And that really concludes our questions. If you had questions about the slides, we will be emailing those out to you. Thank you so much for your attendance today.